Carpal tunnel syndrome is very common. It's one of the most common surgeries done in the United States and one of the most common surgeries I do. Carpal tunnel syndrome specifically is compression of the median nerve at the level of the transverse carpal ligament, which is right at the wrist. If there's any swelling of the tendons and if there's decreased elasticity of that ligament, it becomes a very tight structure. That results in choking of the median nerve essentially at that level. The classic textbook carpal tunnel patient is somebody who has nighttime symptoms and they have pain, numbness, and tingling that go into the index, long, and ring fingers. We see it a little bit more commonly in women. It tends to see it in both genders as they age. Diabetics, people with renal disease, but it is something that's treatable. We prefer to treat it early on if possible. If somebody's kind of in the mild category, we'll try to exhaust the non-operative options, which would be splinting, plus or minus cortisone injections into the carpal canal. When somebody's in the moderate, we may talk more about surgery, and that's making about a 3 to 4 centimeter incision in the base of the palm, and that's considered an open technique. And then there's endoscopic. I prefer to do it endoscopic. We're making a small incision outside of the palm area where it's less sensitive, and then we're just cut that ligament without having to disrupt any other tissues. It's freeing up that transverse carpal ligament so that it's no longer choking that nerve. Once that nerve is relieved, I'll have some patients say that it's the first time they've had a good night's sleep in months or in some cases even years because the hand's no longer waking them up, during the night. I think the big advantage of endoscopic that I've seen is that I think they have less pain initially, and I think the recovery is usually a bit faster.